Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a discussion on the complications of mastoidectomy. So far, I have spoken about the different types of mastoidectomy and what are the steps in each of these different types. And today we'll be discussing about the complications. You can also purchase my notes now. I have added links in the description. Okay, so let's get started. We can classify our complications of mastoidectomy into intraoperative ones and postoperative ones. Postoperative complications can be further divided into early post-op complications and late post-op complications. First, let's discuss what are the different intraoperative complications. So, the most common one over here is bleeding. Now, bleeding can happen during any surgery, but at what point do we call that as a complication in case of mastoidectomy? And why does bleeding happen over here? So there are multiple reasons over here. First of all, it can happen because of injury to multiple different structures. Like, for example, there could be injury to the mastoid emissary vein or dural venous channels or sigmoid sinus. Now, if the sigmoid sinus gets involved, it is actually a very dangerous complication, and this leads to torrential hemorrhage and can even develop air embolism if the wall of the sigmoid sinus gets breached. So, this cause of bleeding will actually be very dangerous. Other than this, it can also happen because of injury to middle meningeal artery or branches of posterior auricular artery or occipital arteries during the time of incision and flap elevation. So, these are due to all the causes of injury to some kind of vessel. Bleeding can also happen when there is any granulation tissue or because of removal of cholesteatoma from its bed. Sometimes it can lead to excessive bleeding. Now, problem with bleeding is it can end up obscuring your surgical field. So, you'll be spending a lot of time trying to clear your surgical field so that you know where you're drilling. So, that will actually lead to increased operative time. So, we have to be very cautious about this by knowing the anatomy properly and knowing which structures lies where and being very cautious when we are drilling into the mastoid. That's how we can prevent this complication. Now, say you have tried to prevent and it has still occurred, how will we manage the case? So that will depend on the structure that has been injured. So if it is a small vessel bleeding, in that case, it can be controlled by bipolar cautery, gel foam, or bone wax. Second is dural bleeding. Dural bleeding can be controlled by gentle pressure and use of some hemostatic agents. Third is if the bleeding is occurring because of the presence of granulation tissue, in that case, we have to cauterize the granulation tissue or pack it with adrenaline soaked pledgets. And general measures would include correcting the BP of the patient and maintaining a good anesthesia and hemostasis for the patient. So that's all about bleeding as a complication of mastoidectomy. Now we'll be talking about a lot of structures that get injured during the time of surgery and that will end up being a complication. And one of the major structures that can get involved in case of mastoidectomy would be injury to the facial nerve. Now, facial nerve is very intimately related to different walls of the middle ear. So, when we are performing mastoidectomy, it comes a lot in our way. So, the most common site over here in cases of in cases of facial nerve injury happening, the most common site would be the tympanic segment. And we see this in about 40 to 45% cases. The second most common site would be the second genu and the vertical segment of the facial nerve. So it is important to remember the most common site is the tympanic segment of the facial nerve. Now, is the risk of injury the same in every case of mastoidectomy? No. The risk is increased in certain conditions. For example, we know that the facial nerve is enclosed in a bony facial canal. So, if there's any congenital dehiscence in this bony facial canal, then the facial nerve will be exposed to the surface. So, while you're drilling, it may come in contact with the burr and cause injury to the facial nerve. So, that is our first risk factor over here. It is also more increased risk in cases of previous surgery, in cases of extensive cholesteatoma involving certain areas of the facial canal, and also if we see that there is an anomalous course of the facial nerve. If the facial nerve does not follow its usual normal anatomical course and it has an anomalous course, it can predispose to increased risk of surgery. Now, say that the facial nerve, how do we prevent this injury to the facial nerve? First of all, we need to have very good knowledge about the anatomy and the different landmarks around it. So, while we are drilling, we have to be constantly aware of the structures around. And more important structures over here would be to look out for the lateral semicircular canal, the oval window, digastric ridge. So, any landmark that will help you in identifying facial nerve. So, I have a separate video on the landmarks of facial nerve in case of a mastoid surgery. You should definitely check it out. Other than this, second thing is we usually use a cutting burr when we are drilling the mastoid, but we have to know when to change our burrs. So, when we are near the facial nerve, we should definitely switch to diamond burr. The risk of injury using a diamond burr reduces significantly. Third is we can also do an intraoperative facial nerve monitoring that can help you in knowing when you have reached very close to the facial nerve and you may end up injuring the nerve. So, these are all the ways we can prevent a facial nerve injury. Last part is let's say we have injured the facial nerve intraoperatively. How will we treat this patient? If the facial nerve has undergone a transection, in that case, we have to perform a primary repair or a grafting procedure. If there is partial injury which is not a transaction, in that case, we can perform a decompression of the facial nerve and start the patient on steroids and eye care to prevent the exposure keratitis of the eye. So, this is about injury to facial nerve as a complication to mastoidectomy. Our next injury is going to be about injury to the chorda tympani nerve. Now, chorda tympani nerve, we know that it exists from the facial nerve in its in its vertical segment. So, it is in close relation to the time when you are performing mastoidectomy. So, it can actually get injured. And if it injures, how does it present? It is important to know that chorda tympani not only supplies taste, but uh, it also has a supply of salivary secretion. So when you chorda tympani nerve gets injured, it can lead to taste disturbance, where the patient may complain of a metallic or a bitter taste, or there can also be temporary reduced salivation. It is very important to remember here that this injury is actually not a fatal one because this is usually transient by itself and it recovers by itself by neural adaptation. So we do not need to worry too much about the fact that in case the chorda tympani nerve injury happens. Next injury is injury to the labyrinth. It can lead to the formation of lateral semicircular canal fistula. Now, how can this happen? This can happen, say, if the cholesteatoma has eroded the lateral semicircular canal, it can actually increase the risk of injury during the time of clearance of the cholesteatoma. So, in these patients, they will present to you with a sudden gush of perilymph. So, they'll be having perilymph leak and they'll complain of vertigo and a sensory neural hearing loss because of damage to the labyrinth. In these cases, how do we treat it? If the matrix is covering the fistula, in that case, we try to preserve it and we do not remove it. But in case we do remove it, in that case, the fistula should be sealed with bone dust and fascia, any kind of fascia like temporalis fascia or some fatty tissue. So that's about injury to the labyrinth or the lateral semicircular canal. Next two injuries would be very dangerous ones. So first one is if there is injury to the dural plate or the tegmen. So when I was talking about mastoidectomy in my previous classes, I have mentioned that the superior limit is usually the dural plate or the tegmen. You should be very aware of its location and not breach it. In case the tegmen plate gets breached, you'll actually end up reaching the dura and the brain matter. So that can lead to CSF leak, dural exposure, brain herniation, and even an increased postoperative meningitis risk. So, it is a very dangerous complication to have. So, you should be very careful around the superior limit of mastoidectomy. In case now, say that you have ended up injuring the dural plate, how do you manage it? If it is a small exposure, in that case, we leave it intact and just cover it up with a fascia. But if we are seeing that there is CSF leaking, that means the dura has been breached. In that case, we have to close up this CSF leak. We have to do a watertight closure with fascia or cartilage. Start the patient on acetazolamide and also bed rest. Next is injury to sigmoid sinus. As I was saying in my first point, that this is actually a very, very dangerous complication to have because it can lead to very profuse bleeding and even air embolism if the wall of the sigmoid sinus has been breached. And in case this happens, our first thing that we need to do is to control it with applying pressure. Apply bone wax, Surgicel, or gel foam. And if it has been lacerated, pack it up with muscle and start the patient on IV fluids. Next injury would be injury to the ossicular chain. Now, when you are in the attic, when you have performed atticotomy and you are trying to see if there is any disease in the attic and you are trying to clear it out, there can be accidental trauma to the different ossicles that are present over there. The most common ossicle that can get involved over here is the incus. So, if there is any injury to any of the ossicles over there, it can lead to the development of conductive hearing loss. And how do we treat it? We treat it with ossiculoplasty. The last intraoperative complication would be injury to the stapedius muscle. So, the stapedius muscle can get injured at various stages of the surgery. So, it can get injured during atticotomy. It can get injured when you are trying to dissect cholesteatoma, which is around the stapes or the oval window. It can even get injured during posterior tympanotomy, where you are trying to go through the facial recess approach. So these are the different times during mastoidectomy when injury to stapedius muscle can happen. So the muscle or the tendon can either get cut, cauterized, or avulsed. Now, if this happens, what will the patient present to you with? So we know that there is a reflex called the stapedial reflex, for which in case there is, if we see that there is a loss of stapedial reflex, the function of stapedius muscle is to dampen any loud sound that reaches us. So the moment you lose the stapedial reflex, it leads to inability to dampen the loud sounds. That leads to the development of hyperacusis. So there is increased sensitivity to loud sound in such patients. So whenever a post-mastoidectomy case comes to you with increased sensitivity to loud sound, you should definitely be suspecting an injury to the stapedius muscle. But oftentimes, the patient may also be asymptomatic, because most of the times what happens, even if there has been an injury to stapedius and it is not able to dampen the loud sound, its function is kind of compensated by the tensor tympani and other central mechanisms. So the patient may end up being asymptomatic despite having an injury to the stapedius muscle. In these cases, usually we do not require any specific treatment because the patients tolerate this very well. But if the patients are very symptomatic and they are complaining of the sensitivity, in that case, you can just reassure the patient. And in very few cases, we may even give a hearing aid with sound compression. So these have been all our intraoperative complications of mastoidectomy. Next, let's look at the postoperative complications. So, as I mentioned before, the postoperative complications can be classified into early and late post-op complications. First, let's talk about the early postoperative complications. So, there can be a hematoma formation. Hematoma formation usually occurs in the post-auricular region. Usually, we perform mastoidectomy through the post-auricular approach, where we give a Weil's post-auricular incision. So, hematoma can occur because of inadequate hemostasis during the time of surgery. These patients would come to you with a swelling in the postauricular region, complaining of pain, and the dressing getting soaked multiple times. Once you have diagnosed the patient as a case of hematoma, we have to evacuate the clot, cauterize any bleeder that you may find, and put a compressive dressing on the ear. So, this is about hematoma. Next is the patient can also have the wound infection or abscess. Usually the wound is in the post-auricular region. So in these cases, why would it happen? It can happen because the field has been contaminated or poor aseptic conditions have been maintained during the time of surgery. So these patients will again, they'll have a swelling in the region, they'll have pain, and they'll also have discharge coming from the wound, and they'll also be febrile. So these are all features that will point towards a case of infected wound. Just like any other infection, in these cases, we'd have to start the patient on IV antibiotics, do drainage of the wound in case there is an abscess formation, and take care of the wound with proper dressing. Next, patient can also have vertigo, but usually these cases have vertigo which is very transient in nature. And this cause of vertigo can be because of labyrinthine irritation during the time of surgery, due to either the presence of suction near the labyrinth or due to the heat dissipating from the burr, or it can even be because of labyrinthitis. These patients will usually complain of postural vertigo and nausea, and we treat them by giving bed rest and vestibular sedatives. Next post-op complication is sensory neural hearing loss. Now, why can this happen? Sensory neural hearing loss can occur either due to acoustic trauma caused by the drill or suction. It can also occur because of labyrinth damage or cochlear concussion. A very severe form of this is something known as dead ear. So, in dead ear, this is a very rare complication, but when it happens, it's a very serious complication. So, we find that they have total sensory neural hearing loss due to labyrinthine trauma or infection. So, if any patient comes to you with sensory neural hearing loss and they are not a case of dead ear, in that case, we manage them with the use of steroids, hyperbaric oxygen if it is available, and usually, unfortunately, if the sensory neural is permanent, if it is very severe. Next is persistent CSF leak. We have been talking before that if there is a tegmen injury or the dural plate has been breached, the dura has been exposed, and if there is a leak in the dura, that can lead to the persistent CSF leak. So sometimes you can even end up missing the tegmen injury, or even if you have found the tegmen injury, it has not been adequately repaired. In these cases, we'll find persistent CSF leak. So the patient will come to you with a watery discharge from their ear and an increased risk of developing meningitis. These cases have to be treated with the repair of the defect, placement of a lumbar drain, and antibiotics. The last early postoperative complication is a delayed facial nerve palsy. This can happen because of thermal trauma to the facial nerve due to the use of burrs near it, due to the development of edema because of manipulation. It can even occur when there has been a tight packing placed. Another cause could be a viral reactivation in the facial nerve. These are all the reasons why you can have a delayed facial nerve palsy in a case of mastoidectomy. In these cases, the various treatment measures include removing the tight pack, starting the patient on steroids, eye care, and physiotherapy. So these have been all the early postoperative complications. Last of all, let's discuss about the late postoperative complications. So here, our most common one would be the development of a residual or a recurrent cholesteatoma. So this can occur because of incomplete clearance or retraction pocket formation. In these cases, the patient will complain of a persistent ear discharge. So, one of the differential diagnoses of a post mastidectomy patient coming to you with persistent ear discharge would be a case of residual or recurrent cholesteatoma. In these cases, you would have to perform a revision surgery for these patients. Next complication is a persistent discharge cavity. Now, what could be the possible cases for this? This is probably due to poor cavity design. Now, there can be multiple reasons of poor cavity design. Either the facial ridge is very high. So, if you do not lower the facial ridge enough, it ends up developing this deep pool at the level of. So, this is the external auditory canal lower wall, and this is the mastoid tip. And the facial ridge lies somewhere over here. So now you have to lower the facial ridge. If the lower facial ridge is lowered properly, this floor of the EAC slopes off gently into the mastoid tip. But if there is a high facial ridge, this will lead to the formation of this deep recess that can actually collect the discharge of the ear. So this could be a possible reason for persistently discharging cavity. Second reason could be because of inadequate myotoplasty or leaving behind residual sac. So these patients will be coming to you with a persistent ear discharge post surgery and even development of granulations. For management of these patients, we'll do a revision mastoidectomy, a cavity obliteration, and meticulous oral toileting in the follow up of the patient. Next is the patient can also develop meatal stenosis. Now, meatal stenosis will occur if there has been an improper myotoplasty or any external auditory canal skin loss. So, the patient will come to you with a narrowed meatus and recurrent discharge. In these cases, we'll again have to perform a revision surgery where we'll do a revision myotoplasty and we can even do skin grafting. Next complication is about tympanic membrane perforation. Now, we can have multiple issues over here. If we have performed a tympanoplasty along with the mastoidectomy, there can be graft failure, there can be reperforation of the tympanic membrane. The tympanic membrane may have lateralized, or there can be atelectasis even. All of these cases, we'll have to perform a revision tympanoplasty. Next is failure of ossiculoplasty. So, in a lot of the canal wall up procedure, even in modified radical mastoidectomy, we do reconstruction of the hearing mechanism by ossiculoplasty. So, there can be failure of the ossiculoplasty because of multiple reasons like prosthesis, extrusion, resorption, and poor eustachian tube function. In these cases, the clinical features would be a persistent conductive hearing loss, because of the damage to the ossicles or loss of ossicular chain. And in these cases, we have to treat it by doing a revision ossiculoplasty. Next complication is caloric vertigo. Now, as the name suggests, this is vertigo when when the labyrinth has been directly stimulated by cold air or water. So, on exposure to cold air or water, the labyrinth gets directly stimulated. And this happens in canal wall down procedures where you have a wide open cavity. So, these patients will actually come to you with a complaint of vertigo when they are trying to bathe or on exposure to any kind of cold air. We will treat these cases by doing a cavity obliteration and taking precautions during water exposure. Our last complication is a cosmetic deformity, which mostly happens in cases of canal wall down procedure, which can happen because of excessive bone removal or even a post-auricular depression. In these cases, we'll manage it with obliteration with fat or cartilage and placement of local flaps. So that's all about the complications of mastoidectomy and how we classify it into intraoperative and postoperative complications, why all of these complications happen, what will the patient present to you with, and how will we treat these cases. If you have any further questions on this, please note them down in the comment section and I'll get back to you.